Yeah, the reasons could be like it is a silent epidemic. It is not, if not one continuously one poison with one or other, so it is keep on increasing. So this is one picture that what is 3,47,46,000 deaths globally per annum. So 91% occur in the countries like India, low middle income group, this thing. And there is a knowledge gap. So knowledge gap, like in the standard MBBS MD curriculums, you take MD, general medicine particularly. So often cover toxicology only superficially. In MBBS we will see only in the forensic medicine. Lack the depth required acute clinical management in the ER. So that was lacking. And resource scarcity is also there. Lack of the specialized training leads to delayed identification of the toxidromes. So toxidromes is a passion in any conference is because we are not being taught from the beginning. And limited knowledge of the novel antidotes. And this question was there, no, the gap is that there are so many thousands of poisons and antidotes were less. So why antidotes are not being invented? So in this scenario, suboptimal critical care for the poison patients. So the bridging the gap between theory and life-saving practices must be there. So for this, of course, research also has to come. And what is a toxicology fellowship? A fellowship is creates a specialist capable of the moving beyond the basic gastric lavage. So in India, what I believe, and now it was there 25 years when I was entered into the clinical practice. It was the only thing, poisoning, just stomach wash and go, and if you are survived, you are lucky, and then it was the situation. And India in particular, the combined AB, now Warangal is the one. So with the highest number of documented poisoning cases, particularly these pesticidal poisoning cases there. So in this scenario, that it involves the mastering of the antidote administration, this one extracorporeal elimination, the dialysis part. So dialysis part is now picking up because the nephrologists are also involved into this poisoning management. So, and of course, the critical care physicians and all has to deal definitely with the multi-organ failure. So, poisoning is not just elimination and giving some antidote. So, beyond that, so the rapid elimination, new methods of elimination, and managing effectively that multi-organ failure. The goal is to produce the practitioners who can lead the poisoning centers. Ashma Madam was telling that we have to develop a poisoning centers. Each medical college or each medical center should have their own poisoning center, and definitely make use of the National Poison Information Centers, AIMS Delhi or CMC Vellore. So wherever it is 24 underutilized, and take them and make your own center, and you may be resourced to the other situations. So what are the, there are specialized post-MD programs, very few are there. So the focusing more on the poisoning, chemical exposures, antidote-based care. Other time the sir was telling it is only the climate change, because the new areas of this poisoning and intoxication will come. These what is called the blasts and these what smoke. All these things are happening. So even fire accidents, because the smoke will come, it's a different kind of poisoning. So from one factory fails, no, it's a mass casualties also can happen. So the bridge between, so other day it is almost summary what I believe, the bridge between emergency medicine, critical care and poison control. So need, yes, rising incidence is the one reason. So pharma related pesticidal poisonings is another, this is very relevant in India. Urban drug overdoses, for now the people, young people, youth, they are living in a different kind of society, so they are easily available. Narcotics or banned drugs, so all rave parties and all those things are there. You cannot trust anyone. So all these can, it was a like it can happen in India like situation. Now it is happening. So for that reason also, the number of toxicology trained people are needed. Need for clinical expertise, rapid decision making, supports the emergency and critical care. So the core curriculum could be clinical toxicology, that is toxicology recognition, stabilization. So if you don't know anything, stabilization. What is stabilization? You learn that is sufficient, and supportive care for unknown poisonings. This was we are discussing. Analytical interpretation of the drug screens. There are so much of toxicology screens. So if the allergy screening is there, because which allergen is causing this thing, like which poisoning. So you can develop, at least if it is not at all available. So you can develop. So it can create the lab data to guide the therapeutic decisions, and environmental also. The management of the occupational hazards, heavy metals and envenomations. So all these things will be a core curriculum in India. So the key skills to taught is the poison management protocols, and if the protocols are not there, should be developed, and antidote use and indications has to be understood very well, and laboratory toxicology, interpretation of the EEG, ECG, radiology. So what were taught now, and critical care support in poisoning, because ultimately you have to save the organs and then save the person, and coordination with the poison information center. So with this attitude, so one has to do a fellowship program, and what is the impact, what is the use? Yes, definitely it will reduce the mortality, timely antidote administration saves the lives, and faster diagnosis will prevent so much of the morbidity, quick administration of the unknown toxins. So like optimization of the ICU use, better triage and resource allocation will come. So this is very, very high impact on the critical care medicine. So same thing I have told. So, and next future scope, advanced developing the new antidotes and protocols for specific to Indian toxins, that is necessary, which is lacking. So if anybody is interested in this line, take a fellowship and progress yourself, and in future maybe specialty, super specialty courses will come. Education integrating the toxicology into the core residency curriculum. In the residency, and unfortunately all our surgeons are not completing their internship in the hospitals, for which, so from the anatomy days they will read for the PG NEET, and for the in the MD they will read for all those things, and they are not learning the practical points. This is a very special situation in India, and establishing these more poison information centers in every state. So I think Ashima Madam will start one center for Telangana. So it is our responsibility to produce that also. So this is like a 1-year fellowship, it is available. But accreditation pathways, faculty requirements, these are the big logistic challenges, and infrastructure, emergency department, you have to align with the poisoning, ICU support system, toxicology labs. So many EDs doesn't have toxicology screening protocols and labs, and there is no tie-up with the poison information center, even if they are available freely. So So curriculum usually the foundations, clinical rotations, advanced toxicology, and 10 and 12 months, last 2 months research and public health modules. Ultimately, we are working for the healthy, poisonless society for our India. So module core skill and research modules are will be there: antidote training, taxonomy recognition, simulation based toxicology workshops and all. So formative, summative at the end. What is the path forward? Integrated training. Advocate for including the mandatory clinical toxicology, rotations in emergency medicine. Actually, I differ here. If the general medicine person is there, so he may need additional information about the toxicology. But emergency medicine will have definitely a clinical toxicology rotations, so that it will be a part of his curriculum, and critical care residency programs also, and expanded fellowships, like encourage more institutions to adopt the. So some private institutions like Indian Society of Toxicology or International Society of so many models also. Whatever is the good which is adopted by some other institution or any university or any country, that can be imbibed. So I think this association can develop one of the fellowship pathway for the same this thing. So probably all stakeholders has to come, and other is the TM track. So this one is there. What is academic and institutional? So DM in medical toxicology. So that is what I am telling you. 3 years for super specialty may be recognized by NMC after select premier institutes and institutional training centers like AIMS New Delhi, Jodhpur, and AIMS Rishikesh, and Kochi and Kochi PGMR. So short-term training also, specialized internships like Tech India and some other NGOs are doing. So like key institutions offering these programs are All India Institute of Medical Sciences Rishikesh is offering 1-year postdoctoral certificate course, and so on Tamil Nadu, MGR Medical University in Chennai. So associate hospitals like Dhanvantari Hospital. So same sort of thing with premier institution like NIMS can have one kind of thing. So other professional bodies also like Indian College of Emergency Medicine are there. So but our own this thing. So some of the few examples only I am telling, but what I strongly believe, so these kind of program knowledge in the form of certificate, in the form of degree, either university accredited or some good accreditation societies can give, it will help in the betterment of this thing. So these are the already given, Dr. Nitya has given these vital centers. And conclusion, toxicology fellowships strengthen the emergency and critical care. India needs more trained specialists. National training programs will greatly improve the patient outcomes. Thank you very much. The dose makes the poison, but the right expertise makes the cure. So the dose, Sarva said, everything is poison, but dose makes. So if it is in the poisonous dose, can be made it as a drug by the experts, for which they have to take the fellowship. And I invite you for what is the international lookout on this fellowship. Thank you very much. Sir,